Man, I got to be honest. Every time he says, all right, recording's going to start now, my face itches. You don't touch your face for 30 minutes on
Oh,
the
now that you
practice
say
session.
that, now all I just want to do is just touch my face.
It's like when somebody says lice and you're like, oh my gosh, my head itches. What
So
the heck?
speaking of lice and head itching, I appreciate you not saying anything about the new haircut.
Oh, I was going to wait,
Were you
till
on when I
everybody
told
got
Chad?
on.
Were you on when I told Chad?
No.
I've literally been cutting my own hair for 20 years. I started it when I was in dental school. You know what I mean? Because I didn't have any money. And so I bought like clippers and I just do it with like the combs, and now that I'm a dentist, I can do things in mirrors. And so I just like pull this mirror out and I do the back, you know what I mean? And I've been doing it very successfully. I've got a beautiful head of hair. And when I do it right, everything looks really good. So anyway, I take this longer comb and I do the whole top first. And then I take a smaller one, I'm blending the sides, right? And as I'm blending the sides, I'm talking to my wife, just like blah, blah, blah. We're talking about our trip over 4th of July. And I'm like, oh my gosh, I missed a spot right there. And then went, zzz, and just was doing a short one on side to side. Like, I know I took it down, like, so it's been a week now. And now I've got like this like 5-year-old buzz cut. It's like, I think my mom used to buzz me when I was little, just like, I'm going to buzz cut this kid for the summer because he's feral and I don't want to have to like stop him to comb his hair. So I was like that buzz cut boy.
Oh.
But anyway, I'm noticing I have a fairly decent shaped head if I ever lose all my hair and I have to do that, but hopefully I never have to do that. So anyway, so yeah, that's where I'm at.
How do
now.
I follow that, man?
I'm just saying that's where I'm at right now. I have a buzz cut I haven't had since I was 5 years old because I screwed up my own hair, which by the way, the next time we get together, I'll have to show you the picture my wife took when it was just one strip of me doing that. So anyway.
Yeah, that's the, you don't want to hear your barber, hairstylist, or contractor say, oops.
Yeah.
In that face, right?
See, I didn't even have to say it to myself because like that internal voice that swears at you sometimes, it did it for me. Like, yeah, geez, this is going to be bad. So anyway.
Well, at least you have a round head.
Yeah, as I said, at least I don't have any lumps either, I think for people that lose their hair, I think there's got to be some people that are really disappointed when they finally shave it and they're like, ugh, the dome isn't maybe as good looking as I thought.
Yeah. Well, and here's the funny thing. I bet everybody who just hopped on this webinar is wondering what they're doing in the wrong room about hairstylists.
That's what this is about today. This has nothing to do with dental sleep. This is all about hairstyling and haircutting. So.
Well, I guess let's respect everybody's time. We are 3 minutes after, so we will stop the banter only momentarily because it's going to come back and forth pretty much for the next hour. I'd like to let you know, welcome everybody. If you're on here, we'd love to hear from you. If you can hit us in the chat, let us know where you're from. So city and state, if you don't mind, and let us know. Chat, just so you guys know, the chat is going to be reserved for answers to our questions, Dr. Manning's questions tonight, as well as any tech issues that you have. We have somebody in the background running tech support, so if you have any tech issues, throw it in the chat. If you have your own burning questions that you brought to our webinar, we want to be here for you. That's the whole goal of tonight. So if you can put those questions as soon as you get them in your brain, stick them through your fingertips, put them in the Q&A section for us. We will likely get to many of them tonight as we get through the content. But for those that, you're going to ask one of those questions we've never heard of before, please stick it in there. We're here for you. We want to answer those questions. So I'm seeing a bunch of folks. We got Georgia representing, Cummings, McDonough, Georgia, Austin, Texas, Tulsa, Atlanta, Yo-Yo from Burlington, North Carolina. I thought Yo-Yo was a California thing. Maybe that's YOLO. You only live once. Just saying. Dr. Hancock, no idea where you're at, Dr. Hancock, but thank you for telling us who you are. Where are you at, man? Oh, he did it in right below there. Yeah, there I go. See, I'm not supposed to be the one scrolling through these things.
Right. We're just the pretty face here. That's all. Or
really?
something.
You're going to start it that early?
Or something.
Or something, yes. All right, so let's get the CE stuff out of the way. You all have heard it before. You're going to hear it again tonight. This is an AGD PACE credited webinar tonight. It is free to you. We are here for you to share as much information in this short time as we possibly can. We have the infamous and wonderful Dr. Greg Manning, who I will get to here in a moment. Our goal tonight is to answer your burning questions, like I said before, about dental sleep medicine. If you have any other burning questions, please don't ask. We have no idea about anything else. And tonight, you get one CE if you hang out for the entire time. We need to verify that you're on, so we will pop a link into the chat at the end of the webinar tonight. If we can show that you've been here for an hour, you click the link, spend anywhere from, I don't know, 18 to 37 seconds, depending on how fast your clicker is. You have to answer a couple of questions. You'll get an auto-generated CE certificate. Link will be in the chat at the end. Separate from that, if you attended tonight and for some reason the link doesn't work, wait an hour after the webinar is done and you will have an email in your inbox. If it's not in your inbox, it's in your spam inbox, we promise. 1 hour after the webinar ends, you'll have a link to click. Like I said, we're here for you. So without further ado, Dr. Greg Manning. You graduated forever long ago. Just kidding.
Yeah.
2006, brand new practice in 2009. Were you unemployed for 3 years? I'm kidding.
Yeah.
Associate for 3
just
years.
making mistakes on other people's patients back then, you know.
In practice for 12 years, and of those, 11 has been with dental sleep medicine. I'm sure you'll get to that. He hails from the wonderful, hot and bothered Gilbert, Arizona. Yes, it's as hot as Phoenix because it's right next door. He's been a diplomat of the American Academy of Dental, or American Sleep and Breathing Academy, pardon me, for 4 years. And I just have to say, everybody, this is, I call him Greg because he's a friend. Dr. Manning is an outstanding clinician. I've been to his practice multiple times. I can attest to this from the patients that give him hugs, sloppy kisses on his cheeks. That's just the old ladies. But bottom line, he's a great doctor with a great message, and he's going to bring his A game tonight, giving you a 30,000-foot view of dental sleep medicine. Greg?
Man, are you sure we don't want to just keep going with that? I mean, I would love to talk about sleep, but what you were saying was really fun. Just keep saying nice things about me. So with that being said, let me just jump on here. Let me just share screen real quick. Make sure, Michael, you let me know if everything's looking good. Is that looking okay?
Yeah.
Okay.
Hey, time out real fast. I have to apologize. I totally messed up as the host non-extraordinaire here. We need to thank our partners. So the sponsors of tonight's event, you all are clients of theirs. That is Midwest Dental, Atlanta Dental, Getsy Dental, and Nashville Dental. We want to thank you all for being clients of theirs. And our message tonight is complimentary based on their participation and your relationship with them. So we want to say thanks to them. Thank you for sharing the slide and saving my bacon.
Yeah.
Now back to you.
I'm here for
Sorry,
you.
buddy.
Awesome. Well, you know what? And I want to say the same thing. Thanks to those that have sponsored that, to have made the invite so that everybody could be here tonight. These are always fun. I'm sitting in a room by myself, talking to myself, and I'm happy to be doing it. You know, like Michael said, in 2009, just to give you a perspective on how super smart I am, I thought that would be a good time to do a startup from scratch. And so we did a startup from scratch in 2009. And, you know, oddly enough, we had far more time on our hands than we had money coming into the practice. So we started looking around for ways to just enhance the income of the practice. And a friend of mine who I went to dental school with came down from the great state of Washington and said, hey, I'm coming down to Phoenix. I'm going to take a class on sleep apnea. You want to come with me? And I went more for the company because I hadn't seen him in a couple of years than I did for the message because I didn't know much about it. And one thing led to another. I joined the Academy of Dental Sleep Medicine and got my name on a list. Somebody found me. That person referred somebody else to somebody else to somebody else. And the next thing you know, we're doing quite a bit of dental sleep. And so I often say that dental sleep medicine found me. I did not go out in search of it. So I commend anybody on here, because that means you're out here looking for it. You're out here looking to do this to enhance your practice. I could tell you that now, 12 years later in my practice, I would be too busy to incorporate dental sleep medicine the way I did initially. My journey into dental sleep medicine, the way I did it, I would never recommend to anybody. It's trial and error. It's arduous. I call it hacking through the jungle with a machete just to try to make a little trail. And luckily for you all, we made this trail, and now we've kind of made the mistakes. We've had the successes, and now we're just here to say, hey, there's the trail. Why don't you follow us through it? Now, that being said, if I were to be doing this now, I would not again be able to do this the way I did it. And as a result, there are a lot more resources out there, like Awaken to Sleep. We do webinars and things, and we'll talk about that as the evening progresses. But just know that this is a doable thing, and it's been a very, very successful part of our practice. I'm, I guess, forever grateful that I had more time than money at one point in my career and decided to incorporate this in there, and love getting other people excited about dental sleep medicine in their practice and watching them grow their practices from a dental sleep medicine standpoint. So with that being said, I'm sure we have people on here that are doing dental sleep medicine. We have some that may have never even heard of the word apnea before. So I want to kind of start off, and for many of you that are already doing this or you've been to courses, you may look at this first little bit as just kind of a review. It may be a boring review. It may be a super stimulating review. But let's just start with the bare bones. And let me just start with a couple of useful definitions. Sleep apnea is, in essence, when we stop breathing while we're sleeping. We reduce the airflow to 90 to 100% for 10 seconds or longer. And that is going to be accompanied by oxygen desaturation in our blood. So apnea, for the layman, is basically we stop breathing. We stop breathing for 10 seconds or longer in our sleep. Now, apnea, while it is very dangerous and can be deadly, apnea also has this like annoying little cousin brother called hypopnea, which can also be dangerous and deadly, because we'll actually reduce the airflow of somewhere between that 30 and 90% for 10 seconds or longer, but we get this drop in blood oxygen. And really, overall, this drop in blood oxygen is what's most nerve-wracking for our body and most deadly to our body over the course of time. We need that oxygen to live. And so if we're not breathing, or we're breathing so shallow that we're not able to bring in enough oxygen to get enough oxygen to our body through our night, we're going to have consequences, long-term consequences, short-term consequences. So apneas and hypopneas are what happen to us if we have this disorder called obstructive sleep apnea. Now, the way we determine, how bad things are is an index of apneas and hypopneas per hour. So the total numbers of apneas and hypopneas that we have per hour is called the apnea-hypopnea index. As a secondary diagnostic, and let me just go back. Apnea-hypopnea index is how we diagnose people, mild, moderate, and severe. We use these amounts to do that. And so we'll get those amounts here in just a minute. But as a secondary diagnostic criteria, sometimes we'll see this respiratory disturbance index, which is in essence the AHI with the total number of respiratory related arousals, where we might have something in our breathing that causes us to have to wake up, maybe subconsciously wake up. But in essence, we're going to today talk mostly about apneas, hypopneas, and then this apnea-hypopnea index. And we're not going to spend a ton of time on it. Like Michael said, this is a 30,000 foot view. I would never, ever expect that after a webinar that's 45 minutes that you guys will be able to just take whatever you learned today and run with it and be super successful. This is kind of something that took us years to do in our practice. We've boiled it down to where it can be weeks and months, to be very successful. But hopefully it's enough to wet your whistle to say like, hey, maybe I could do this. Maybe this is something I want to look into a little bit further. So when we have healthy breathing, we have an open airway, whether that's through the nasal pharynx, oral pharynx, or where they meet up in the back of the oral pharynx and all the way through the trachea into our lungs. We don't have anything that would impede this normal breathing. It goes in, it goes out, it moistens, it cleans, and everything feels good. We don't make a lot of noise while we're doing that. Now, when we have the soft palate, get to the back of the nasal oral pharynx junction back there, and we breathe in, and the vibration of that soft palate and uvula kind of cruise across the back of that oral pharynx, we hear snoring. And that is the snoring that is the vibration of that soft palate uvula against the back of our throat. The other thing is that anytime, we take air, a volume of air, and we try to move it through someplace that is pinched off, we're going to get noise, kind of like if you blow up a balloon and then you kind of pull out the sides and you go, because air is trying to get through an area that is maybe narrowed somewhat, and that makes noise. And so that's kind of what snoring is. We get the vibration and that constricted airway that causes that air to make noise as it's passing through there. Snoring in and of itself is not deadly. Snoring is annoying. Snoring is deadly if you're living with a spouse that doesn't like it. Maybe it can be deadly. At least it hurts your ribs when they're, always giving you one of those to wake you up. But snoring is also a sign of potentially a bigger problem. And for a lot of patients with obstructive sleep apnea, snoring is one of the hallmarks of that. But in and of itself, snoring is not deadly. It is when it is accompanied by these apneas and hypopneas, where we get a complete blockage or such a reduced airflow that we actually are not getting enough oxygen to support our body. And as we do that, the brain kind of has to wake up. Again, this is subconsciously, but the brain wakes up, determines that the hyoid bone has fallen backwards and brought the hypoglossal muscle and tongue with it. And that tongue and soft palate have basically choked us out. And it has to stimulate the hypoglossal muscle to pull the hyoid bone forward, which in turn pulls the base of the tongue forward. And we take a big breath again. And unless we're keeping that open on our own, if it blocks, the brain is going to have to do this constantly through the night as we relax, and that tongue falls backwards and chokes us out. So that is, in essence, sleep apnea in a nutshell. If I were going to sum it up, I would sum it up a lot like this.
When you breathe, air travels through your nose, down the throat, through the windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the soft palate to vibrate. This causes snoring. In some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often, this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea. Procedures to stiffen or shorten the soft palate can improve snoring. Procedures that open the airway in the back of the throat can improve sleep apnea.
Wasn't that great? It sounded a lot like what I just said. Only I probably could have just played that video and I could have done it without saying anything. But like most dentists, we love to hear the sound of our own voice and we love to sound smart. And so that's the way I did it. But in essence, I feel like between the explanations that we just went through in this video, we should probably all kind of understand now what obstructive sleep apnea is, what causes it, see how naturally it can happen to really anybody. But that is nutshell sleep apnea. Now, what does this look like in real life? Let's just ease up there, Trigger. This is a video of somebody that is having multiple apneas as the course of this video goes on. This video is like 7 minutes long, and we're not going to watch the whole thing. But if you notice, this guy's not breathing right now. You can see there's some effort. His tongue's in the way, so his mouth's starting to move open, and now he kind of changes body positions. His brain is awake. He's not going to remember that he did this. But he got some oxygen in. These are big breaths. Normally when we're sleeping, we wouldn't be going. But he has restored at this point the oxygen levels. His brain is satisfied with the fact that his oxygen has been restored. He relaxes again, and lo and behold, he stops breathing. Now, if you look at his chest, it's kind of like an effort. There's an effort trying to get that rise and fall, trying to get that diaphragm to push and pull air down into the lungs, but it's not happening. You can see the mouth start to open because he's trying so hard to get the air to come through there, but it's not happening until his brain wakes up, right? Tightens that up, change a little bit of body position, takes a breath. These are big breaths to try to restore that oxygen. Oxygen's been restored. The brain is now saying, hey, finally we got the oxygen we needed. And lo and behold, again, the relax sets in, the throat closes off, and we're not breathing again. And this is going to happen to this guy sort of all night long. And this is very severe apnea, but you kind of get the idea of what that looks like. Now, for patients that this happens to them, say less than 5 times an hour, that is considered non-apneic. If this is happening less than 5 times an hour and we're keeping our oxygen levels above 90%, that is great. That's normal. That's healthy. Now, if we have this happen anywhere from 5 to 15 times an hour, and we're seeing O2 saturation dropping below 90% at any given time, we're going to call this mild sleep apnea. Now, if that number of times per hour averages out to be 15 to 30, and we're seeing maybe even a bigger drop in our O2 saturation, where we might dip a time or two down to 80, 85%, maybe even a little bit lower, then we would call that moderate when it's happening 15 to 30 times per hour. And then anything over 30 with a big decrease in oxygen saturation, we're going to call that severe sleep apnea. So that's the way we diagnose sleep apnea. We diagnose it based on the amount of episodes that we have per hour. Again, mild 5 to 15, moderate 15 to 30. Anything over 30 is considered severe as long as they're having these oxygen desaturations. So in essence, that is apnea in a nutshell. Great. Now we know what it is. What do we do about it? Why are we talking about this as dentists? We're not pulmonologists. We're not neurologists. But we have the ability to help these patients. Now, the big reason why these patients, we see the guy having the apnea, we see the guy having these problems sleeping at night. But bigger than that, there is a big health impact associated with that. Now, part of the reason why there's such a problem with sleep apnea in this country is that there are walking around an estimated 30 million people that have some form, mild, moderate, or severe, of sleep apnea. These people are hurting. They're having trouble. Their physical health, their mental health, their alertness, their ability to function is being affected in some way by this. And these 30 million people, in essence, they're struggling unless they get some help. Now, how many of these people have even been diagnosed to say, hey, all of these problems that you're having, all of these physical symptoms and potential health problems that you're having may be associated with your sleep apnea? Only 3 million of those have even been diagnosed so that they recognize that a lot of these symptoms that they have are coming from apnea. The rest of them are hurting and don't even really know why. Now, out of that 3 million people that have been diagnosed, less than 1 million of those, less than a third of those patients are actually being treated. And why are they not being treated? Well, they're not being treated because the treatment modalities that have been prescribed to them are not effective. It would basically be like saying, you have high blood pressure, you need to take this pill. And it's the only pill that works for high blood pressure. And I take it and it makes me super gassy. And it's an embarrassment. And I decide that I'm never going to take that pill again. Well, now I'm choosing not to be treated because the treatment modality has side effects that I don't like. And unfortunately, that is kind of what happens with our sleep apnea patients so often through our general medicine, and we'll go through this in a minute, are offered a treatment modality in positive air pressure called CPAP. And that CPAP is invasive to them and it bothers either their night's sleep or their partner's night's sleep. And so they choose not to take that pill, if we're following that same analogy. So there needs to be an alternative to that. And that is why dentists step in. And I've often said, if you have a problem, give it to a dentist. We're pretty handy with stuff. We don't just give up on stuff real easy. So that problem was handed to dentists years ago. And again, I commend you for picking up the baton here and wanting to help moving forward with this with this sort of epidemic. Michael, are you jumping in there?
Greg, I am. A couple of questions for you. Since we're on the topic, you're a DSM expert, and we want to drop as many nuggets as we can.
Sure.
How in your practice, how do you find your CPAP intolerant patients? Number one. And then number two, do you have any information on the Philips recall stuffs that's in the news?
Yes.
And
I got both of those. Now, the patients that are CPAP intolerant in my practice are really easy to find because I have a 6-foot banner that almost goes like floor to ceiling in my lobby that says, if you're struggling with your CPAP, please talk to me. Those are the easy ones. It's those other ones that are in this 30 million that have never been diagnosed, and we got to get them to a diagnosis. We got to get them to figure out that a lot of their problems that they sense, and even some of the problems that they don't sense that are going to become problems in the future, are due to sleep apnea. Those are the harder ones to find. And we're going to, again, 30,000 foot view, talk about how we find those patients, but we're also, that is kind of who we need to focus on. Because those that have been diagnosed and they're just not using their CPAP, if they walk into my door, one of the first things they're going to see is this big, huge poster with a dude wearing a CPAP that looks miserable and saying, if you're one of these people that don't tolerate your CPAP, let's talk about an alternative. So that's the way I do it in my practice, and in all my ops, there's a smaller version of that in case they miss the 6-footer in the lobby. But I think there's a bigger opportunity. When I first started, that's all I was focused on. I was just focused on CPAP failures. I was just focused on CPAP intolerant. And I thought I was going to be the bridging of the gap between that 3 million diagnosed and that 750,000 treated. That's where I thought I was going to live. Now I find that I live more in the blue section. I find I live more in the let's figure this out for you and help you down this path. Now, that being said, I have jumped on a couple of calls with Somnomed, who is a medical supplier of oral appliance therapies. They have been on the forefront of trying to figure out how we're going to deal with this Philips recall. Philips, again, has recalled a massive amount of their CPAP machines. They are leading the game. Them and ResMed are the two big players. Right now is a very, very hot time to try to start in dental sleep medicine because the need for that is going to be absolutely crazy over the next 12 to 18 months. For as great of a company as Philips is, there's some issues with their CPAP machines. They've had to recall those. They figure it could be anywhere from 12 to 24 months before they're able to restock everybody and get them back to that. Now, during that time, it's going to be a triage situation. Our very severe patients are going to get the small number of CPAP machines that are available, and it's going to leave patients that are not super severe, but still have pain points and problems that are going to need to be treated. And for the first time really ever, I think general medicine is saying, well, crap, we're going to have to rely on the dentists for this. Whereas for a long time, they thought we were just kind of some farce. Not everybody, because I have plenty of referral sources that really believe in us, and we're able to show them very objectively how well we're treating their patients. But I think for the first time ever, as this triage is out, they're finally looking to dentists and saying, hey, you got to help us out because we're going to have people dying if we don't get them treated. And we can't treat them right now because of supply and demand. So that is about the Philips recall. This is a great time to get into it because there's going to be a real need for this coming up. So Michael, was that kind of where we wanted to be with that?
And here I'm acting like a rookie with my mic muted while I'm talking to you. Yes, awesome. You hit it. Let me state it in bullet points because you gave us a lot of the why. Philips is one of the largest CPAP manufacturers. Just under 4 million CPAPs globally are being recalled. Like Dr. Manning said, it will take 12 to 24 months estimated to get all those patients triaged. We need your help. That's the bottom line. So easiest way that we've seen in practices like Dr. Manning's, when he says in that blue area, if you're writing notes down, you're asking patients, have you ever been diagnosed with CPAP or sleep apnea? Do you have a CPAP? Are you using it? Those are your standard 3. Add a 4th one. Are you aware that there's a Philips recall? Has that affected you?
That's
How
a
are you
great
handling
question.
that?
Yeah.
That's it. And then, you know what? Maybe it's a referral back to their MD so that they can triage it. Now that MD needs to know about you because you can help them in a couple weeks versus maybe 2 years. So, sorry. I'll be quiet now and give the
Perfect.
stage back to you, man.
No, listen, and we didn't, I hadn't even put in a slide about the recall. You know, Michael and I teach a course once a month. It's a weekend course. And I'm definitely planning on bringing that up a lot in that course, because there is going to be an incredible need. And just some of the phone calls I've had and Zoom meetings I've had with some of the, with SomnoMed, you know, there's guys that are talking about, even the dentists trying to treat this, that they're not even going to be able to keep up with the load of people that are going to be coming in. So great opportunity right now for practice growth in dental sleep medicine. Now we're talking about the pain points that these patients have. If you look at, statistically speaking, patients with hypertension and drug resistant, specifically drug resistant hypertension, I mean, they're basically married to sleep apnea. Sleep apnea and patients with drug resistant hypertension, almost all of them have it. Now, 3/4 of all patients that we would consider to be obese, or that have congestive heart failure, or that have type 2 diabetes, 3/4 of these also have sleep apnea. So you can see right away that these patients that are having some of these problems, you know, is it chicken or is it egg? Are they having these problems because they're obese, or because they already have congestive heart failure, or, and probably more accurately, are they having these problems like congestive heart failure, type 2 diabetes, maybe obesity, because of their sleep apnea and the body's ability to handle that kind of stuff? So definite health impact associated with sleep apnea. The other thing that patients, you know, as dental patients, now one of the things I always tell patients is I do a really, really awesome DO on 19. I spend tons of time carving tertiary anatomy on that thing, and everybody loves them. People stand up when I do a DO on number 19, and they're so happy, and they give me big hugs and kisses because it's just such a fantastic DO. And I'm joking because nobody wants to talk about their teeth. And I had to actually show them the little dark spot on the x-ray for them to even want to do a DO on number 19. But when it comes to sleep apnea, patients want to talk about it because these are actual pain points. That DO on number 19, that little dark spot that they had no idea was there, that wasn't hurting them, they weren't even sensitive. And I've had to convince them to come in and let me get real invasive in their mouth and get into their personal space quite a bit. They didn't want anything to do with that. They didn't want to talk about it. They didn't want to do it. They didn't want to pay for it. But when it comes to sleep apnea, it's the exact opposite. If you start talking to patients about some of these things that are complications, drowsiness, their medications for obesity, hypertension, diabetes, heart attacks, they want to talk about this, especially when you talk about the ones that are really hurting them, like drowsiness and fatigue, like morning headaches, like memory loss, where they just feel like they're in a fog, brain fog. Their memory is not what it used to be. You know, of course, the top left one, impotence. You know, I love talking about the firmness of erections with my patients. It's like my favorite thing to do. And I'm kidding, I never talk about that. But if I were to talk about that, and occasionally have, it's kind of like these other things, like headaches and like brain fog and just this crazy daytime drowsiness that they have. They want to talk about that with you. They want to have this conversation with you because you are going to help them. So unlike most things that we do in dentistry where they don't want us to talk about any of it, they do want to talk about this because if there's a chance you can help, they want to talk to you about it. Past that health impact, there has become more and more sort of a social impact. The quality of life of patients with sleep apnea is really slipping. They don't have energy to do the things that they like doing. They don't have energy for their family. By the time they're finished with a day of work, they don't want to go home and spend any time with their spouse or their children. They have this chronic irritability, decreased sex drive, memory loss, daytime fatigue. All of these things suck the quality out of these people's lives, and they're hurting. They don't like this. They want to feel like they used to. And unfortunately, something that they don't oftentimes even know is happening is causing a lot of these things. And it's amazing to see, you know, Michael jokes around about my hugs and kisses from my patients, but I really do have patients that come in and are so thrilled when we've gotten the quality of their life even that much better with treating sleep related issues, that they're just happy. And so that is kind of one of these social impacts. You know, this is something I find, I don't know, I'm not a marriage counselor. I got to think that there's probably statistics that branch off of this, that it's an estimated 25% of couples in the US are sleeping apart. I don't know if that's good for marriage or not. I know that if you're snoring and that's why you're sleeping apart, then it might be good, but is that healthy? Is that what couples want to be doing, sleeping apart? I don't know what things are like in some of these areas, Atlanta, Tulsa, I saw North Dakota or North Carolina, Texas. I imagine some of these places are doing what Arizona is doing. Arizona is actually absolutely like blowing up as far as new construction and home building, and people are coming in from different states to live here in Arizona. And one of my guilty pleasures, I like walking through the model homes just to see what everybody's doing. And it was funny because we are seeing more and more of something like this. You see there's this middle kind of dining room, family room, kitchen, and then two different masters, because just because I snore doesn't mean I don't want to have my own master closet and bathroom. Or we're seeing master bedrooms with small rooms off of them that it's just like a sleeping quarters within the master bedroom, so that we can wall off dad because he's snoring too loud and mom can't sleep. So these are social impacts that are happening. And as dentists, we get a chance to make a difference. Now, obviously, like I said, in a 45 to 50-minute discussion, we're not going to be able to go through how you can make a difference specifically. You're probably not going to leave here and make a huge difference, but you can. You have the ability as a dentist to change lives, not just teeth. So, Michael, talk to me. How are we making a difference?
No, I had to go back to the, you can't serve two masters.
Yeah.
I will be here all week. Just kidding. No, I want to actually pulling the audience in. If you've been screening patients for a long time, I know hygiene does a lot of that stuff, and that's not really quite your bag. But when you're talking to patients in your chair, or hygiene's doing it and they hand off to you, Mrs. Jones doesn't really appreciate that you talk to her about her snoring either. No difference than Fred doesn't want you to talk about the impotence, right? Maybe that's a little bit of a different conversation, but talk to us about the Mrs. Jones part. How do you gently, comedically, like you do you, how do you do that to screen?
Obviously everybody's going to be different because you want to be authentic. You want to be you. Your patients come to you because you're you. But yeah, a lot of that happens in hygiene. Now, look, I'm looking at that. If I go back, that slide, here where we're talking about the fact that 83% of people with drug-resistant hypertension and 3/4 of all people with obesity, congestive heart failure, type 2 diabetes, pacemakers, hypertension, coronary artery, all of those type of people are super high incidence and risk of having obstructive sleep apnea. Have the hygienist look at the health history. Mm-hmm. Now, one of the things that we can talk about is, and we're not going to have a lot of time to go through this, but in our hygiene department, we see so many things intraorally that would also kind of tip us off that maybe these patients have obstructive sleep apnea. Some of these things might be a class 2 tendency, like pushed back lower jaw, to where maybe there's already not a lot of space back there because the same size tongue is in a little bit smaller space. We may see like that they've had their bicuspids removed for orthodontics because there wasn't a lot of space there too. That's one of them. But we also see things like scalloped tongue, large tongue, those ones that we hate to prep number 18 on as a crown because their tongue is like massive and it's way back there. These are the kind of things that you would see as a hygienist while you're cleaning. And then if you look over at the health history and they're also suffering from some of these other things, at some point we start to say, hey, look, this is kind of my lame way of saying it, like some of these signs and symptoms are sort of, they quack like a sleep apnea duck and they walk like a sleep apnea duck. At that point, we can use these things that the patients already recognize to ask a couple of probing questions like, hey, have you been told that you snore at night? If they get offended by that type of question after we've talked to them, like, hey, I noticed some scalloping on the side of your tongue. I noticed that you have, congestive heart failure. I noticed you're incredibly obese, however you want to make that, and then ask them, say, have you ever been told that you snore at night? Do you ever wake up with like morning headaches that are driving you crazy? Again, at some point, these patients want to talk about it. Mrs. Jones may be embarrassed to talk about it, but if you're talking about things that you're seeing on a health history and intraorally, and then you say, hey, do you snore at night? Do you have morning headaches? Are you like by 2 o'clock in the afternoon, do you need to find like caffeine to just make it through the rest of your day? Do you have this excessive daytime tiredness? At that point, patients are like, yeah, kind of. At that point, you can kind of say the same thing, like, man, this kind of looks like it might all come from the same thing. You might not be getting great sleep. And at that point, we talk to them about wanting to look into being diagnosed or having a diagnostic test done to see if all of these things may actually be a sleep apnea duck. We would not know that until we tested them while they're sleeping. So, when we, sorry, I'm going to go back to when we go to this, we're going to talk a little bit, sorry, I'm being kind of prompted, but because we are going to talk about some of these screening things right now. When we talk about who is Mrs. Jones in our practice, who are these people that have sleep apnea? I always say this: it's not like spotting a toupee. That's easy. You walk by with a toupee, bam, I can see that a mile away. But who has sleep apnea? In this top slide right here, yeah, you would think that this guy in the top corner, he's a heavy set guy. He's got a real thick neck, probably a big barrel chest. There's a really good chance based on the general health of this guy on the top left that he is suffering from sleep apnea. Do I know that by looking at him? No, because I've never tested him when he's sleeping, but you could make some assumptions. Now, if you look on the bottom right, this beautiful woman, who is 110 pounds, 5'3", not that fun to go out to lunch with because she brings her own salad dressing in her purse, eats like a rabbit, goes exercises every day, walks a couple miles every day, and also 43 and a half years ago, birthed yours truly. My mother has sleep apnea. You wouldn't know by looking at her. What about her says sleep apnea? And she's had it for years. She's had it since she was probably in her 40s. We used to camp and be in our trailer, and we used to think it was our dad, but me and my brother couldn't sleep at night because of the snoring. We thought it was dad. Dad took one for the team. Yeah, but he knew it was mom. And it's kind of been like that. So we can't just say, oh, because he looks like the guy on the top left, he's got sleep apnea, we're going to have that conversation. But what about if my mom comes in and you see that she's on blood pressure medication and she's on cholesterol medication and she may have acid reflux and she's got a scalloped tongue, and she talks about how for as much exercise and good eating as she does, she's still tired all the time, and she wakes up every morning with headaches, and she's got wear patterns on her teeth from clenching and grinding. All of those things are clinical signs and symptoms that we can be looking for, and then having that conversation with our patients. The more and more we do that, the more and more it becomes second nature. But there are so many reasons why dentists got deputized to be the alternative, because we see so many intraoral signs and symptoms of obstructive sleep apnea, because this is where it's all getting started. So many of these things start right in the mouth, and so many of the fallout things we can see in the mouth. And at that point, we start asking questions. If you offend somebody, just know you're doing it in the name of trying to save their life potentially. So that's the way I handle it. I tend to be a little bit more laissez-faire in my verbiage sometimes, because it's my personality. Some people I think my patients come to me because of that, but other people's patients go to them because of the way they are. And you find that within yourself and how that looks with your team, but we got to know what we're looking for. And, that's where, a more deep dive course might help you calibrate your hygienists to start looking for those things, and offering them a few things that they might be able to say that might start those conversations, and then you can bring that home. So from a screening standpoint, the things that we see in the mouth, again, large tongue, tonsils, extended uvula, wear and tear on teeth. There's a lot of things, when I look at this, bruxism is big, GERD is a big one. This little Malampati classification, that little picture in the bottom right, I actually have laminated cards in each one of my operatories. And if I suspect that somebody is suffering from sleep apnea and they show up as a class 3 or class 4 on that Malampati, I actually have them hold that thing. Up and look in a mirror, and then stick their tongue out and say, which one do you think you are? And a lot of times they're like, oh, I look like I'm a 3. It looks like I'm a 4. And you say, yeah, I think so too. And like the incidence of people with obstructive sleep apnea or problems sleeping or snoring, they go way, way up when you're a 3 or a 4. we got to test you to see what's happening while you're sleeping. These are easy conversations that get easier with time. But again, how many things do we see in the mouth that we could start these conversations with? The patients sometimes already know about. Maybe they're already bugged by the fact that they've got wear on their teeth because they grind their teeth. Maybe their jaws are sore because they're grinding their teeth. And all of these things are related to obstructive sleep apnea. Again, macroglossids, that big tongue, the acid reflux, bruxism, scalloping in the tongue, attrition on the teeth. If they have this narrow, high arching palate because they're not posturing their tongue correctly up in there, so it hasn't formed correctly because of the way they're holding their tongue in the back of their throat instead of anterior and up in their palate. Again, any kind of oropharyngeal crowding, that Mallampati classification, bicuspid extraction. Again, I think our hygienists see this a ton. We see like a patient that looks like they're doing a good job with hygiene at home. They don't have a lot of bone loss, but they've got this red inflamed gum tissue. And likely it's because they're a mouth breather associated with sleep apnea. They might just be mouth breathing and drying that out and it stays irritated. So all of these are signs and symptoms that we're going to see as dentists. And so often we treat them as a dentist. We treat them with our dental hat on and say, well, we need to treat your gums, or we need to do this, or we need to do that. I think as a sleep dentist, so often I have to take that hat off, put on what does this mean in the general broader sense of medicine? And what might I be able to do dentally, but also medically, or what might this be the fallout? And I think you kind of get what I'm saying as I'm stammering here, that sometimes we have to, as sleep dentists, go back and forth between what's dental as a fallout from something medical, what is some medical thing that has some dental fallout. There's this back and forth. We for years as dentists wanted to become part of the dental community. We want so bad to be real doctors, and this is kind of our chance to do that. We've wanted it for so long. Well, now we get the chance, because this is where dental meets medicine wholeheartedly. So now, once we determine that it quacks like a duck and it walks like an OSA duck, really, we're never going to know what that is until we test them when they're sleeping. I can tell you a lot of things about a patient while they're awake, but I don't care what's happening when they're awake, because when they're awake, they're not purposely choking themselves out and decreasing the oxygen to the point where it's causing cell death. That's only happening when they're sleeping. So I would really like to know what's happening when they're sleeping. And so from a testing standpoint, this has become a big barrier. This has become a huge barrier for patients, partly because traditional modalities for testing were the guy on the right, these PSG or polysomnogram. These are an in-clinic, overnight, inpatient, hospital setting type of test where you sleep on somebody else's bed with somebody else's pillow, and you got all these things hanging off of you. They're taped to you, and all of those wires that are all hanging off of him, they're plugged into a wall, and somebody's watching them, watching what these wires are meaning. They may not be watching the patient sleep the whole night, but watching what these wires are telling the wall. This is not a great way to try to bring this to your patients and say, hey, look, all of these things that we're talking about that you're saying, man, I would love for these pain points to go away. I would love to wake up with no morning headaches. I would love to, have more energy during the day. I would love to not nod off while I'm waiting for a stoplight to go green. All of those things sometimes don't ever find fruition because of the test that they have to go through on the right side. Conversely, if we can test somebody in their own bed with their own pillow, in the comfort of their own home, with something that's far less invasive, not plugged into the wall. It does have a little nasal cannula and a little pulse ox on the finger, but how much more peaceful. I mean, look at this guy on the left. He just looks so peaceful. And his wife's so happy. I mean, look at, she looks peaceful. That's what you would expect more from a home test versus this polysomnogram in lab test. So if we can get people to home test, that barrier almost starts going away. So in our practice, when we get these people talked about, and we're talking about this sleep apnea duck, that you're walking and talking and all this kind of stuff, we've got to find out what's happening while they're sleeping. So I have a handful of these units that I can just send home with them. I'll say, hey, look, I don't know what's happening when you're sleeping, but this thing could find out. And I hand that to them, and they test in their own home. And then we have these results read by a boarded sleep physician. I am not a sleep physician. I have the results read. They send me the results, and then we talk to the patients about how we can help them treat the problem that now has been diagnosed properly with an FDA approved test by a boarded sleep physician to read that test. We can now become that person that can step in and say, hey, look, this is kind of getting started in your mouth. Let's talk about how we can work with that same mouth to maybe treat some of these things. So these things have far less channels. They have far less wires that need to come off of it, because we're looking for sleep apnea. And sleep apnea, you just need to know if they're snoring, if they've got airflow, if there's a lot of that effort you saw in that guy in the black shirt. You know, we want to look at the O2 saturation. We want to look at heart rate, and we want to be able to see when these things are happening. Am I on my back? Am I on my stomach? Am I on my side? These kind of things are the few things that we want to know. I don't want to know if you have restless leg syndrome. I don't want to know if you have periodic limb movements. I don't want to know if you have, you know, some kind of REM-related narcolepsy. That's not what I've just screened for. I have screened for somebody that has sleep apnea. And by the way, of all the sleep-related disorders that you can have, all of the crappy stuff that can happen or weird stuff that can happen while you're sleeping, obstructive sleep apnea far and away is the majority of those. Far and away, the majority of all sleep-related breathing disorders are sleep apnea. So the fact that we have a test now that just tests for the one that's like 90% of the time it's sleep apnea, and this test is only checking for sleep apnea, you know, what a great way to do that, and a comfortable way to do that. At that point, we get, if we have a diagnosis, if we find that AHI is getting to that point, and we have a diagnosis, we need to treat. Now, really quickly, before we move into the Q&A, as far as treatment options for these patients, this is not a great way to treat patients. There's a lot of invasiveness in some of the treatment modalities, because we want to be left alone while we're sleeping. We don't want to be invaded upon while we're sleeping. So this CPAP, which stands for continuous positive air pressure, that's the mask, that's the hose, that's the machine that sits next to them that forces air into their basically the whole windpipe from oral and nasal pharynx all the way down to the lungs. Just holds it open like a balloon with continuous air pressure. It's like the clown with the balloon, you know, he blows that thing up, and then it'd be like he holds that pressure all night long so that it stays open, and we breathe through that. That's invasive. There's a reason why only a third of people that have been diagnosed with sleep apnea are being treated, because most of them are being treated with a CPAP machine and they don't tolerate that. There are a handful of surgeries. They are finding that surgeries more and more are becoming less and less effective and extremely invasive. So we do have those two as an option, surgery or CPAP. Those are the ones that traditionally have been used, and those are the ones that traditionally have been the things that are not working for people. That's where these mandibular advancement devices come in. And without belaboring the point, it is a device that we make, protecting the jaw joint, protecting the dentition, but also stabilizing the lower jaw so that it does not allow for the lower jaw to fall down and backwards to obstruct the pharynx to the trachea and stop us from breathing. Now, the last thing that patients that have been diagnosed can do is nothing. They can do nothing, and if they do nothing, they will end up a statistic of sleep apnea. And that statistic looks like this. If you're a smoker, statistically speaking, that could take 5 years off the end of your life. If you have apnea, that will take 7 years off the end of your life. This is a big deal. So really, at the end of the day, we just want to take nothing off the table. When we talk about oral appliance therapy, there are a handful of really great appliances out there. This is an offering made by Somnomed called the Avant. I'm personally slept with that last night. I used the Avant. I love it. It's very comfortable. It is a digitally fabricated milled device that is very thin and very comfortable. But in essence, it stabilizes my lower jaw so it doesn't fall backwards. I have moderate sleep apnea when I don't use it. And I have a lot of symptoms when I don't use it, of fatigue and snoring and sore throats and headaches and all of the crappy things that happen. I also had been diagnosed with high blood pressure as a young man. So fit. I wish you could see me. I'm like an Adonis. I'm so fit. You'd just be surprised. But without my appliance, I'm a mess. I'm not happy. I'm all of those things that are there around those bubbles. I'm all the bad things when I don't have it. So oral appliance therapy is really, really dramatically changing the game. Um, the idea again of these is that we stabilize the mandible and we keep people breathing. Now, when would we use these? Well, when I first started and I took my first course, they said, you can go ahead and treat anybody with mild sleep apnea. Anybody that's mild, just go ahead and do that. You don't need to have them try a CPAP first. You don't need to have them do this. You don't need to have them do that. Just go ahead and jump right into any of those mild cases. But if they're moderate or severe, really should try to tell them to start with a CPAP. And if they don't like the CPAP, well, then you can treat them. But a couple of years later, in 2015, the guidelines changed from the American Academy of Sleep Medicine, and they said anybody who's mild or moderate could jump right into an oral appliance. We have been now FDA cleared as primary therapy for mild and moderate cases. We're also cleared for severe cases, but if they are CPAP intolerant, there's a form you have to fill out that says, I can't use my CPAP, I've tried, it doesn't work for these reasons, and they sign that. And then even some of my most favorite patients that love me to the moon and back would be my severe patients. And even though they may not be treated as well with an oral appliance as they would with a CPAP, the fact that we are a better than nothing and we're changing from how bad they are to less bad, they notice the biggest difference almost. And so that is how we can help. That's how we can step in and take away these pain points from people. That is what we can do. And I mean, look, if you want to know the nuts and bolts of it, if you say, hey, I want to make one tomorrow, there's a lot of legal things you probably should be doing that we would go over in the thing. But in essence, take an upper lower impression and a special kind of bite and make one of these and pop it in their mouth like you would a night guard. That seems pretty easy. It's all of the other things that make dental sleep medicine something that's a little more difficult to implement in a practice. How do I get this going? If you want to make appliances, take an upper and lower impression, take a special bite that I could show you how to take in, a minute, and throw these things in people's mouth. But what are we doing for those patients? How are we helping those patients? How are we able to explain to the patients if they're being helped or they're not being helped? That is where becoming a sleep dentist is different than just I'm making a piece of plastic to put in somebody's mouth. So again, the one thing that we want to do, this is a quote from Michael. Michael, I just heard him jump on there. This is a quote from Michael. The only thing that we want to do as we screen and test patients as we move into that treatment phase is take nothing off the table. Send them for surgery, give them a CPAP, give them an oral appliance long before you ever say, like, you've got a deadly disease. Go ahead and do nothing about it. That's not a great place to be.
Greg, you're good. I was saying we got a few minutes left, and I want to make sure we hop into the opportunity. And if they're interested, like what do you do from here? So
well, one of the things, kind of the last thing I really wanted to say before we talk about where I would go, if it were me, and not only if, I'll tell you that it is going to be me, is that we've talked almost this whole webinar about how we're going to help patients. And that is a great drive when you start doing dental sleep, is helping patients. But there's, what's in it for me? Let me just tell you that sleep has been a six-figure boon to my practice for years. It takes 3 or 4 appliances, maybe 4 or 5 appliances to generate $10,000 per month. There are probably that many people that came in through your hygiene practice today, 4 or 5 a day, that probably came in that could use your help. They just need to be found, cultivated, excavated out of your practice to become sleep patients instead of just dental patients. So what would I do? How would I start? Let me just tell you right away, before we talk about a course that would really be beneficial for you and your team. This is a team-driven thing. Start to finish in a sleep patient, I don't spend more than a half an hour with them in the course of a year. This is not something that takes a lot of time in my practice. Now, why does it not take a lot of time? Because the team is calibrated and the team is the one who handles a lot of the nuts and bolts. And let me just tell you, because we're going to talk about a course that I would highly, highly recommend taking, not just because I'm teaching it, actually because I'm teaching it. It's amazing. Michael and I and Chad from Awaken to Sleep are going to be teaching a course that we want to talk about. I have had, through the course of this last year in COVID, an absolute nightmare of a time keeping myself staffed. I have some employees that have been with me for 10 years. I've got this core of people that have been with me for 10 years, but we've added probably 4 or 5 new team members, staff members over the last year. they are not calibrated. They do not know what we know as our sort of core that have been there forever. When I need my team up to snuff, I send them through this course. And in fact, the course that's coming up in July, my whole team is going to take that course with me because I need to get them calibrated. I need to get my team up to snuff on where they need to be so that they're at the same level as the rest of my team. And where I go for that is Awaken to Sleep. I feel like I wouldn't work with them. Just my conscience wouldn't let me work with them if I didn't feel like they just really had everything together. Now that's me saying that in front of Michael, so take it with a grain of salt. But we have been doing these courses now for the better part of a year since we've had to go on virtual courses. And it's amazing that the statistics tracking over the last year is that 8 out of the 10 doctors that go through this course and go through some of the coaching and some of the metrics with Awaken to Sleep are doing at least 3 appliances per month and generating right around that $10,000 a month after working with Awaken to Sleep. So that is me saying I'm not Awaken to Sleep. I am Greg, who has a practice in Gilbert, but I use them for my interpretations for my sleep studies. I use them for my equipment. I use them for a resource. I use their website and all of their online content as a resource because it is valuable. And not only that, but the course is valuable enough that I'm paying my team to come in on a weekend to take this course with me because I need to get them kind of recalibrated, re-excited about it. And so that's what we're doing. So Michael, take it away as far as what the offer is for this. Look at these cute guys in the bottom corner. I mean, this course, is it going to get any better than that?
Yes, it gets a lot better than that. On to what's good about the course. If you loved the way we dialogued tonight, you'll love the course. It's just more of this. There's a lot of movement. No one speaks for longer than an hour. Lots of movement as far as speakers go. We have breakout rooms. We keep the max capacity of each course to 15 practices. That's 15. And in addition to that, everybody who attends gets 14 CEs. So this ticket price that's on the screen here with the coupon code or the link for July, that $397 covers you as the doctor and 4 of your staff members. It's not fair for us to say that it's a team-driven process and then not invite your team. So you pay for your ticket, they come for free. If you actually bring all 4 team members, it's $5 per CE. I guarantee it's the funniest $5 per CE that you're going to spend this entire calendar year. We have a blast. We're going to give you a lot of insight and a lot of information about workflows, how to do it in the practice. Frankly, if you have interest in bringing this into your practice, this is the singular recommendation that we have. Come to the course. If you can, go to July's course. We have, I believe, 9 slots left, unless somebody's already signed up tonight. So 9 slots for July. It's first come, first serve. That's the website if you want to take advantage of it. I know we're going to post it in the chat here in a second. Outside of that, if you can't make July, that's the last weekend, last couple of days in the month, last weekend this month. If you can't make July, please talk to your rep. They can get you a discount code where you can get the same discount on a different weekend. So we have the course every month. Find one that works for you if you're interested in dental sleep medicine, and we're happy to help you out.
Yeah, and Michael, look, the thing about it is I just said my team is attending. We're one of the people in the July course. I'm trying to recalibrate. I have 2 new hygienists, a new assistant, and 2 new front desk. I need them all up to the level where everybody else is at. And so we're going to be taking that course on July 30th and 31st. That is me saying I'm really excited about the course enough to where I'm having my team come. But man, 2 of these hygienists are thrilled that they're getting 14 CEs that they basically don't have to pay for. When I told them that, they were like, "No, yeah, we're in." You know what I mean? So this is a great deal as far as the CE goes. But I think more than the CE, which is great, the information is pretty valuable.
Yep. So real quick, y'all, pardon me, that's my best, y'all. I know it probably sucked. I'm from California. Don't hold it against me. We are going to move into Q&A. Greg, we usually get the question, can we go back to the link? So if you want to just go back to that slide 1, so they know what address to go to. Thank you. But as far as Q&A, I want to hit these questions. If you all have questions, please throw them in the Q&A. We've got a handful here. If you've got to leave, you're welcome to leave, because the link is going to be or is already in the chat for your CEs. That said, we're going to stay until all your questions are answered, because we said we're here for you. We mean it. So if you can hang out, hang out. Let's keep talking. One question, I believe it's George or Josh. I can't remember. Sorry, George or Josh. Somebody a while ago in the chat said, hey, in Atlanta, we have to wait until a physician wants us to get involved with dental sleep medicine. You're absolutely correct. The state of Georgia requires that the physician do the ordering of the home sleep test. It does not preclude you from owning the sleep test. So you're absolutely right. We have to talk about workflow further than tonight. And in the state of Georgia, you need to include a physician in the starting component versus just the interpretation for the sleep study. We have you covered. If you guys are interested in that, we can either schedule a consult call with you for free, or you can attend the course. But there is a integrated workflow that allows you to bring in that sleep doctor ahead of time. They order the home sleep test, and now you're off and running, just like what Dr. Manning said tonight. So there's a solution for you.
Yeah, and if there's anybody from New Jersey, I believe Georgia and New Jersey are the two states where there's one little wrinkle. It's not a complete dead end. There's a little wrinkle that's worked out, but yeah, Georgia, New Jersey. Sorry. Dang.
Yeah, Dr.
Governor
Rose,
Kemp. See if you can get something done about that.
Dr. Rose, thanks so much. She said, see you in July. Greg, I think she was saying that to you, to be clear. But
okay.
Yeah, we'll look forward to it.
Absolutely.
Dr. White had a question. Do you have a questionnaire, sleep questionnaire that you can share? Greg, I would say if you want to share the names of the ones that you use.
Yeah, sure. There are a couple of universal sort of medically recognized screening questionnaires. One's called an Epworth sleepiness scale, and the other one is called a Stop Bang. Those two, you can find one on the internet. Just find a copy of them on the internet. Those are stock questionnaires. Those are subjective. Those are very subjective as far as you're asking patients how they feel. Now, as far as like more in-depth questionnaires, that is one of the things that can be very specific to your practice, depending on what your health history looks like and what kind of information you're trying to get out of patients when it comes to sleep. And there are a lot of good ones. Now, for me and my money, one of the things that I really like about Awaken to Sleep is they actually have an online content on what they call the Sleep Hero Network. If you see this on the side behind the offer, it says Sleep Hero Network at the top. On the Sleep Hero Network, they have what's called a forms library. There's literally dozens and dozens and dozens of forms, from letters that you can send to physicians, to patients, to insurance companies, to forms that you can have patients fill out, screeners, different things like that. And there's not a form that they don't have. There's plenty of forms that they have that I don't use. There's definitely an abundance there. But on the Sleep Hero Network, there's a forms library. And for as long as I've been doing sleep medicine, I still pay a monthly fee to have access to Sleep Hero Network, because I just find it to be super valuable.
And I would say also, Dr. White, you're on the money as far as where your questions are going. This is part 1 of 3 webinars in the series. Next month, we're actually going to be covering screening in detail. So we'll spend the entire hour with our executive sleep coach, Chad Wooters, who does this with practices day in and day out regularly. So the next webinar, if you all want to register for it, is going to be specifically on the topic of screening. When you register, at the end of that webinar, we do send out a couple of forms. Additionally, back to the course, I know we've kind of plugged this a little bit, but if you come to the course, we have an 86-page notes manual that has all of the important slides from 2 days. We have an additional 30-something page workbook that has all of the template forms that you would need to start your program. We don't want to hold back. We want to absolutely help you go do better work. And that's what we're here for. So if you want all of the forms and to hop right in, the course is a great spot. If you're still kind of thinking about it and you just want to know about screening, grab that registration for the webinar next month, and we'll talk just about screening. Dr. Manning, you mentioned, so somebody asked about your personal appliance. You mentioned the one that you slept with last night. Could you give us the name and the appliance that you
Yes.
personally use?
The name of the appliance is Avant, AVANT. It's made by Somnomed. It's extremely comfortable, and it's easily titratable for, that doesn't mean anything to anybody right now, but it's easily titratable. My quick and dirty personal story, there is a lake that is 5 hours from my home. They do houseboats, and it's a big vacation for us. I got off work. We drove up to that lake. We were going to pick up the houseboat the next day, stayed in a hotel, looked in my backpack, and I'd forgotten my appliance. It was 10:30 at night. I turned around and drove home to my house 5 hours, and then 5 hours back, because I did not want to go on a basically trailer on the water, a houseboat for 8 days with my family and friends without it. It's just the way it is for me. Once you're treated for sleep apnea, you know you're being treated for sleep apnea. And that is, I've had a lot, what I'm getting at is I've had a lot of appliances. I've tried 4 or 5 different types over the last 10 years since my initial diagnosis. And right now, the Avant is my boy. I like it.
Cool. I'm being messaged by our team that I messed up earlier with the course. I forgot to mention that if you attend the course, you get over $2,000 in coupons towards the appliances with different manufacturers. The Somnomed Avant is one of those. So getting your personal appliance, just like Dr. Manning has, and for your first handful of patients, you're going to get a discount off of their cases. So if you are doing sleep or you're interested in doing it, that's also free to everybody who attends the course. So you get some vouchers for those manufacturers. Okay, so we've covered getting the physician in before we start the testing process for Georgia. Screening. There was another question. Sorry, guys. I'm not the guy who scrolls for this. Oh, reminder, if you cannot attend the July course, that's totally okay. You can still get the same discount, but you've got to talk to your rep. So please reach out to them to get the discount code for a different date. Okay, here it is. There's a new one. What's your thoughts on the Silent Night appliance? Is it similarly as successful as the Avant?
Yeah, so Silent Night is non-titratable. So when you get that back from the lab, well, it is titratable in a sense. It is not FDA approved as a oral sleep appliance for the purposes of billing a medical code. It's designed as a snore guard. It should be billed out as a snore guard. The Silent Night has its place in our world, but it is not an FDA approved sleep or oral appliance. It's not an FDA approved oral appliance.
Yeah. Somebody asked a question, how can you be a silent apneic? Can I take that one?
Yes, please.
Okay. So there are some surgeries that cut out stuff in your throat that are the noisemakers, like your uvula, your tonsils, all of that stuff that starts to flap when it collapses. If those things are cut out or they are genetically very short, you basically don't have the alarm, i.e. snoring, but you can still have apnea. Apnea's primary culprit or cause is the tongue, as Dr. Manning mentioned earlier tonight. So if you still have a tongue and you've got an airway, you have the potential of sleep apnea. Most of your patients have those two things. So one more thing that I did want to mention that wasn't asked, but I just want to add this in. It's hard to understand numbers in relation to the whole country. So let me speak to your specific practice. 25 to 38% of patients in a general dentistry office are at risk for having obstructive sleep apnea or an airway condition. 25 to 38%. So just think about it in those numbers. How many active patients have you seen in the last 12 to 18 months? Take a quarter of those and be conservative. That's how many people are sitting there already before you get a single word of mouth referral. Most practices that we work with, like Dr. Manning said, that start with the 3 to 5 a month range, and they're happy with that and they're just kind of chugging along. That number alone would take them typically 3 to 4 years to get through their existing patient base of just those high-risk patients. You got a lot of folks that need help and they're trusting you. we want to help you along the way to give them more information and more options. So that's really the goal. Silent apneic. Yeah, I think we're good. All right.
Oh, we made it.
Buddy. We made it. And it's 8:15 East Coast time. So
oh yes, go home with your families, people.
That's why the questions started tapering off.
Yeah. Well, look, there's questions that didn't get asked that will be answered during the course. So highly recommend if you're looking to do this, we'd love to see you back in the course.
Yep. And thanks y'all for spending your night with us. We appreciate it. Again, if you didn't get a chance to click the link in the chat, 1 hour from now, that email will be in your inbox. Don't forget it. And we're here for you. So thanks so much. Have a good night.
Bye, everybody.